Welcome to MedAxiom Heart Talk, the podcast where cardiovascular thought leaders come together for one ultimate goal: to continually advance cardiovascular health care for all. MedAxiom Heart Talk starts now.
Hi, my name is Joe Sasson. I'm the Executive Vice President of MedAxiom Ventures. And with me today is Lee Lewis, the Area Vice President for Arthur J. Gallagher and Company, and Eric Haberichter, the CEO and co-founder of Access HealthNet. Guys, thanks for being here with me today.
Thank you.
So we are fresh out of the keynote session at the MedAxiom Fall 18 CV Transforum here in Austin, Texas. And I think it was a wonderful session. I think a lot of eyebrows went up and people were really shocked at some of the things that they heard and some of the things that you helped educate them on. One of them specifically, Lee, was something that you said, and it was that there are large self-insured employers that are tracking the performance of providers without them even knowing it at this point in time, and that they're really paying attention to the metrics that are coming out of the provision of care. Can you tell us about what some of those are in the cardiovascular space and why employers are looking at those?
Yeah. Within healthcare, more data over the last decade has started to come out for providers of all types. Medicare and Medicaid have begun publishing different kinds of data. Cost data has begun to make its way into the national conversation ever since transparency became a common attribute in 2007. And so more data around pricing, around quality, around outcomes. You have nonprofits like the Leapfrog Group who have entered the conversation and are starting to gather data. All of this has culminated into an environment that is just, ripe for an employer to be able to take, engage, and begin to do procurement of healthcare services, just like we procure everything else, from laptops to legal services.
So in this age of taking a look at this new level of data that's out there, what is it that a provider group whose metrics are being tracked by 60% of the employed patients, more or less, as you think about them as a whole, what is it they can do to kind of be successful as we enter this new realm?
If I'm a provider who is looking to be competitive and to really win in this kind of a marketplace, I'm going to get very clear about what my costs are and how I can reduce them, just like any other business does. Finding efficiencies and finding better ways to run the business side of a practice to be more efficient. That's not to say that I'm going to be, colder or more business-like or transactional with my patients. It's just to reduce the bureaucracies that might get in the way and cost a lot, create more simplicity, and allow your doctors to do what they do best and what they want to do, which is take care of patients. The second thing is I'm going to look at quality, which is defined as what are my complication rates, my readmission rates, am I having a lot of mistakes come out of my practice, am I following the best evidence-based care, and am I ensuring that I'm delivering the right therapy to the right patient? Am I getting the right diagnosis every time? And looking to make constant improvement. The third thing I'm looking at internally to make sure that I'm offering great value to employers and to anyone else to take good care of patients is I'm going to look at, am I being overly aggressive in my care? Am I offering more services just so I can inflate my bill? Am I looking to earn more by doing more, whether it's medically appropriate or not? In the past, we've been able to get away with that. In the future, we won't be.
Yeah. Well, and I understand completely your take on that, and I know in your intent is that sometimes a lot of that's not intentional, and I think it's maybe adhering to established protocols and making sure that we're not overtreating and making sure that we're doing the right thing at the right time for the right patient, is I think what I'm hearing from your message. Is that about right?
That's exactly right.
Okay. Now, Eric, as we are taking a look at some of the things Lee's talking about, and as these measures are coming down and we're taking a look at quality, we're taking a look at cost, we're taking a look at internal operations, a piece of this still comes down to how are we paying providers? And you talked today a lot about the advanced payment models that are out there. What are you seeing in the evolution of some of the advanced payment models with the self-insureds?
Well, the employers and their employees, the plan together, they're concerned about the unit cost, and they're looking at driving down the unit cost and increasing the quality of care at the same time, which together is value. And I want to answer the question you asked Lee just a tiny bit. And what Lee said was we want to look at appropriateness of care, not overtreating, and all of that. And I'm going to just for a moment, because I come from the provider world, let's just suggest that that's not necessarily the only driver, and that there's other drivers we can address first. And in cardiology, there's a very obvious one. So I'm going to pick on the city I'm from, Milwaukee, Wisconsin. There are many, many, many cardiac facilities, many owned by the same institution. There's a severe shortage of skilled cardiac nurses, a severe shortage of skilled technologists on every level. There's also, if we have 3 facilities, we have one that is the cleanest, that has the best outcomes, that has the best service model. We've spent a lot of time, really since the 80s, growing and growing and growing and growing the footprint of medicine. I think in many ways for good reasons. We have an aging population, we'll need more cardiology. But the rules of supply and demand say that if we dilute the talent over too large of an area, yes, we need it for acute emergent care, but for elective or programmable or schedulable care, creating more efficiencies within our systems will allow us to maximize revenue or contribution, which is what we call it in the hospital world, without decreasing profitability or quality of service. In fact, we can increase service while increasing contribution, and by using best practices in a smaller footprint, but still serving the broad-based needs of the acute care patient, we can achieve the triple aim: better outcomes, lower cost, higher satisfaction. Physicians that have to travel from site to site to site with unskilled nurses, not their A-team everywhere they go, that drives burnout. So why don't we think creatively about a more of an ambulatory type strategy where we're using existing infrastructure, maximizing the efficiencies like every other business does, applying things like lean principles and Six Sigma to the world of healthcare, and not just grow footprint for the sake of growing footprint. As far as how are the APMs going to attract that? If I'm a system that has become more efficient, more cost effective, I can deliver higher quality care at a lower price at a better level of contribution. Like anything else, if I'm very good at it and I'm very efficient and I do what needs to be done when it needs to be done, and I control my supply chain very carefully, that's not lowering the pay that's going to the institution or to the surgeon, the cardiologist, or anyone else. It's just reducing my supply chain and overhead cost. And overhead and supply chain are not healthcare. So if we focus on outcomes and care, we can increase contribution and value. And that will attract employers through things like direct contracts.
So I want to build on that, and thank you, because that is very insightful in terms of the whole landscape of how we operate in that system. I want to come back to that direct contracting piece, because you gave a couple ends of the spectrum in terms of provider friendliness of APMs in your talk. And I think on the least friendly side, what shocked people was retrospective-based, reference-based pricing. And that's another thing I really don't feel we need to get into right now. But on the flip side of that, an employer-friendly model is the direct contracting model, where a large employer can contract directly with a provider for a defined bundle of services. Can you tell us about how that model particularly, which is very provider-friendly, is evolving and what that's doing to the space?
Mm-hmm. I think there's 2 flavors of that. One is where a large employer or a group of large employers go to a system or a group of systems and say, we want to pay you a percentage of Medicare. And we all agree in advance we'll pay 150 or 200%, whatever that number is, or 100%. That's probably not going to happen, but say 150, 200. The other is to look at things that we can create, like bundles, that's what the industry calls them, or episodic case rates around things that are a little bit more predictable. You know, when someone's having a heart attack, we don't want anyone shopping for health care in the ambulance. We hope that they know where the good hospital is. They're going to go to that new, efficient center of excellence because they're going to get better care there. We all know that. But when it is an elective thing, like a stress test, like, I don't know, a valve replacement that's not needed to be done acutely, can we, as an employer or a plan and a hospital, agree to a price upfront that makes sense so that we can eliminate repricing and the PPO layers and all of those things that take money out of the provider's hands and put it in the hands of the folks that are just processing bills. And that's really what a direct contract is. It's reducing the number of people that touch the bill. I think on average right now the bill gets touched 7 times. What if it gets just touched once? We all know every time it gets touched, someone takes something. No one touches that bill for free. So if we can reduce the number of touches, we can reduce the overhead and therefore return contribution back to the provider, which means that they can, some of that overhead reduction that I was talking about earlier happens outside of the provider's organization, and it actually happens in the payment world, which frankly is where it can happen very rapidly. That world can change more rapidly than can the provider world. Mm-hmm. The payment world isn't all about buildings and staff. It's about AI and computer systems, and they're already lean. They're already efficient. And that's it. And the other thing that I think is very important, and this is what we do, and I'm not here to plug what we do, but is creating a shopping experience that is, a web-based experience. I'm not going to say what we're doing is the Amazon of healthcare. We're not that advanced yet. But if folks can go out and with the help of a trusted advocate, of their doctor, or some other sort of medical coach, look at those quality metrics and say, here are 3 excellent cardiac experiences that you can choose from. And as an employer, I'm going to allow you to see those 3 excellent choices at an enhanced benefit, typically no out-of-pocket cost. It's a win-win.
Yeah, I think so. I guess have one question for each of you, and then we'll close out today, and that is, if you are running a cardiovascular practice, be it integrated with a hospital or standalone private group where it's physician-owned by their shareholders, what is the number one thing that they can do to be successful in the coming environment in terms of jumbo employers, in terms of these self-pay options, in terms of direct contracting, in terms of getting leaner? What's the one takeaway that you would leave with somebody?
Really don't. For me, if I'm in that position, I'm going to think about value. If I can find a way to offer terrific services at a reasonable price, I can look around and figure out what all my competitors are charging. Can I figure out how to be the best priced option in my area? Can I beat the best price in my area by 10 or 15%? Can I do that profitably? And can I do that without sacrificing anything in terms of a patient experience that is consumer grade, like you would get at any major retail setting? If I can offer that level of consumer grade experience to the patient, I can deliver it at a really good price. That's the major goal that every person should be thinking about, because if you can get there, you will stand to win in sort of the new medical economy that's coming.
Eric, thoughts?
I'd echo that with a slight nuance. And what I would say is drive quality and predictability. Tightly control the things that you can to drive more positive outcomes and reduce variability of outcome. By reducing the variability of outcome, inherently the maximum charge will drop. And if you can take your range and lower it to where, instead of in the range of PPO prices that are out there now, say 10 to 20, you can consistently not be 5, but be between 10 and 15 or 12, you're going to win in that employer space because you eliminate the risk to the higher part. And I believe that this is an achievable goal for most quality-oriented facilities. Reduce variability, drive quality metrics, and standardize practices to a level that is reasonably achievable using data whenever possible.
Well, gentlemen, I appreciate you joining us and sharing your insights both on the stage and off. So, Lee, Eric, thank you guys very much, and I hope you enjoy the rest of your conference.
Pleasure.
Will do.
You've been listening to MedAxiom Heart Talk, the podcast where cardiovascular thought leaders come together to advance healthcare. You can follow MedAxiom on LinkedIn, Twitter, and Facebook. If you haven't yet, please be sure to subscribe, rate, and review this podcast. Join us next week for another MedAxiom Heart Talk, and thanks for listening.